Sanjay
Sir,
Rai. Are you Sautik?
yes, sir.
Sautik. Okay, hi Sautik. How are you?
Sir, I am fine.
Good.
It's very good to see you. And will you be presenting anything on?
Yeah,
Just
I will share the screen. Yeah,
okay, okay. So you will be screen sharing the presentation for your side.
yeah.
Okay. Good evening, delegates. I am Dr. Shobtik Majumdar, the organizing secretary for SAMSACON 2.0. And today we have with us Dr. Sanjay Rai, and he is the principal investigator for the COVAXIN trials at AIIMS New Delhi. And he is also a professor at the Department of Community Medicine of All India Institute of Medical Sciences, New Delhi. So over to you, sir.
Thank you. We have 10 minutes time. So should I start?
Yes, sir. We are already live on YouTube and our delegates are watching already.
Okay. So thank you, thank you, Dr. Sautik. Very good evening to all those who are attending this virtual conference of South Asian Medical Student Association 2020 virtual conference. First of all, I would like to thank organizers, especially Dr. Saptik, for giving me this opportunity to share this special occasion with all of you. I have been asked to speak on this COVID-19 trajectory and role of vaccine in India. And so what I will do, I will share a few PowerPoint slides and I will try to explain all this. Okay, so here is just 1 minute. Okay, so I will speak on this COVID-19 trajectory in India and also the role of vaccine in India. Okay, first of all, again, I would like to thank Dr. Sriya Jha and Dr. Anvita Khetan. They have prepared these slides for me. Um, this would be my outline of presentation. I will talk little bit about this background and epidemiology of COVID-19, the global situation, India COVID-19 situation, then vaccine and its role. So Indian trajectory, mainly my focus will be on Indian trajectory and then vaccine and its role. What are the challenges and the way forward? Um, we all know these coronavirus as a group of RNA viruses um, causing diseases mainly in the mammals and birds, other animals, and human is a incidental host for this virus. The name originated from a Latin word, corona means crown. And because of the appearance of this virus crown-like, this name came. First time in 1960. And the few cases were, the first time in human cases were reported and identified by scientists in 1960, these coronaviruses. So there are mainly four main subgroup of these coronaviruses, alpha, beta, gamma, and delta. And thus, currently, there are total six known this virus group of the viruses causing disease in human. And the current one, COVID-19, the virus which is causing COVID-19 disease, the name of the virus is SARS-CoV-2, is the your seventh virus. So the first four, they are causing common cold and very mild to with very mild to symptoms, not this very severe symptoms. But other coronavirus like SARS, MERS, and this SARS-CoV-2, They may cause mild to severe symptoms, like this SARS coronavirus. This was first time identified in 2002-3 in again from China. And the problem was the case fatality rate was around 10% in this SARS-CoV. Then MERS-CoV, this was from the Middle East in 2012-13. A scientist identified this group of coronavirus, and they found, 1 minute. I want to remove these photographs from here. It's hindering my, okay. Okay, then this MERS-CoV originated from the Middle East, and still few countries are endemic for this. And the case fatality rate is very high for this Middle East respiratory syndrome coronavirus, almost 30 to 40%. And the seventh one, the latest one, is the seventh in this group, that is SARS-CoV-2 virus, and this is causing corona virus disease 19, COVID-19 disease. So this virus, the name of the virus is SARS-CoV-2, SARS severe acute respiratory syndrome coronavirus 2, and the name of the disease is COVID-19. We all know a small virus, this virus was originated in the last week of December from the China. How this was originated, it's still very controversial. So I'm not going to discuss about how this virus was originated. There are various theories, but originated from China. This is confirmed. Although now they are denying. No, we first reported from China. China is denying that this virus originated from China. Then regarding immunity, definitely entire population is susceptible. It's a completely new virus. So nobody is having a pre-existing immunity against this virus. Immunity appears, it's a self-limiting virus. So immunity appears, IgM appears usually after 7 days. And then IgG appears after 7 days, but detectable level usually appears after 2 weeks of infection. IgG detectable level. So what is the level of protection? We have limited knowledge till date. And what is the duration of protection? Really, it's still very controversial. A few publications we have suggest that up to 4 to 5 months we are protected. Few says after 3 months this IgG level is declined, and after 3 months we are unable to detect. So there are various controversy about the duration of protection. But if you see the overall infection and then the protection, more than 3.5 crore cases have already occurred throughout the world, and the reinfection cases are very few. That means whatever global evidence we have, we can say that up to at least for 7th to 8th month, we are protected. These are the clinical fever. Majority have this fever, almost 80 to 85%, and most probably because of this reason, screening for fever is one of the containment measure. So this is about the global scenario. We all know United States, if in terms of number, United States is reporting, they have reported more than 75 lakh cases till date, with almost deaths where. How can I remove these photographs from my screen? Is there any way to remove? Okay, so now I have removed these photographs. So with more than 2 lakh deaths, India, in terms of total number of cases, we are second. But in terms of per day, total number of reported cases, these are the reported cases. These are not the actual infections. So these are the reported cases. So India, per day, we are reporting almost since last 1 month, somewhere between 75,000 to 1 lakh cases. So since last 1 month, almost in terms of per day reporting cases, we are number 1. Otherwise, in total, our case fatality rate is definitely lower than the many other countries. And if you compare with the top 10 countries, so definitely our case fatality rate is lower. If you compare with United States, it's a 2.8, whereas our is 1.5, Brazil 3, Russia. In few European countries, it's more than 5, in between 5 to 10. And we know there are many explanations for this low case fatality rate. And one could be your population structure. We have more young population than this. And actually, in overall Asia, this case fatality rate is low if you compare with other developed country and European countries. So one possible reason could be like in Europe, if you see the overall elderly population percentage, it's around more than 60 year of age, it's around 25%. Whereas in our country, it's 9% only. And we all know this disease, COVID-19, is more severe in those in elderly and those with comorbid condition. Although the risk of infection is same for everybody, but the risk of severity is more in elderly. So this could be low case fatality rate could be because of our young population, one reason, or because of other factor also, like very prevalent this high prevalence of coronavirus common cold infection, and maybe these are producing cross immunity. This could be another reason. We have generated few evidences also, like BCG is also playing a role, but we don't have sufficient evidence. But there are some hypotheses that BCG also playing some role. So this is the what trajectory about your COVID-19 situation as on 7th October. If you see the graph, almost United States, it's a decline throughout if you for country. In India also, last few weeks, the trend is decline trend. Brazil, it's already declined. Russia, for quite some time, it was a decline trend, but now it's a increasing trend, upward trend. Argentina is a upward trend. So these are the few countries. You must have heard about this tale about the second wave in few European countries also, in India also. Many news or electronic media, print media, and also many experts, they reported that there is a second wave in India in few cities like Delhi. So if you want to understand about this second wave, then a clear-cut understanding of dynamics of this COVID transmission is very important. See, currently we don't have any vaccine. Currently we don't have any very effective treatment for COVID-19. So it's a self-limiting disease. What we have only non-pharmaceutical interventions. In few countries, they adopted these non-pharmaceutical interventions very strictly, including lockdown and other measures. So if you are suppressing this spread of virus through lockdown or very strict measures, then what will happen? You cannot keep all these lockdown or these strict measures for an indefinite period. So whenever you will lift this lockdown and other strict measures, then resurgence will occur. Resurgence is bound to occur in that situation. And this happened in these countries like UK, Spain, Italy, France. They decreased this number of cases through strict measures. Italy and also, so that's why now when they lift these strict measures, then the resurgence occurred. In USA and Russia, it's not the resurgence. Almost there was slight dip, and then so resurgence we can only say if the infection is very low near the baseline, and then there is a upward trend. Then we can say. In India, if you compare like this happened in Delhi, many experts said that Delhi there is a second wave after. It's very unlikely that that was a second wave. Why? I will explain here in one. See, with this picture, I will explain why this was not a second wave. What happened in Delhi? Delhi, till date, we have 3 rounds of this sero survey. The first round was conducted between June 27 to July 10. And that time, during that time, we found that in North Delhi, Northeast Delhi district, Sahadra district, Central district, the seroprevalence was above 25%. That means, and this was the bare minimum number that time. Serosurveillance, there are some limitation of serosurveillance because of the sensitivity of the test. And also now we know that after some time, 3 or 4 months, there is a gradual decline in the IgG level. And through this serosurveillance, we detect only IgG level. And that is the humoral response. But if you see the number of cases, in May and June, the maximum number of cases were reported from these districts, and these red color districts, right? And serosurveillance reports also suggested that, okay, the maximum infection were there that time. In subsequent month, what happened? The number of cases were less reported. These districts reported less number of cases, and other districts like Southwest district, West district, and South districts, during June-July serosurveillance, they had only less than 20% of the total seroprevalence. Now currently we are reporting maximum number of cases from there. These districts, North districts, the Central districts and North districts, they are not reporting many cases. The main number, and the second, this happened because of the total number of tests. If you compare these two survey, so from 22% to 29%, there was an increase to almost more than 6%. If you consider Delhi population 2 crore, that means per day around 40,000 infection occurred. And we tested almost 20,000 cases per day in Delhi. And we detected, that time we detected around 2,000 per day. Then suddenly in August and in September, we increased our total tests. We now in September, we tested almost 60,000 per day. And this was one of the reasons of this increase in number of cases. So I'll go back to this slide where I left. So in India, since last few weeks, we are seeing that overall total number of cases are declined. So about India, this virus is not an indigenous virus, it's an immigrant virus and came to this country from China, Iran, Arab countries, Italy, and other European countries. The first 3 cases were reported from China. They were the students from Kerala, and they came on 30th January, February 2, and February 3. So these were the cases, and all these 3 cases had the travel history of 1. So actually they were the students. Till 1st March, other than these 3 cases, no fresh cases were reported from in India. Then subsequently, March onwards, the number of cases were reported, and currently more than 65 lakh cases were reported. So India is one of the hardest hit country in Asia, not in Asia, now it's in the entire world. And currently we are contributing to 20% of the total cases and 10% of the total global deaths. And almost all part of this country, India, either it's in metro cities or village or slum area, peri-urban area, urban area, rural area, from every corner of this country, now we are reporting the cases of COVID-19. And all these serosurveillance, two serosurveillance done by Indian Council of Medical Research at Pan India level. And as per this serosurveillance report, now we can say that this disease has spread to almost all part of this country with a wide community spread. And what is the main problem with this? Our whole emphasis is on controlling this COVID-19 pandemic. So due to preoccupation of the entire health system with COVID-19 response, other national health programs have received limited attention and they are suffering, including maternal and child health program, including our immunization program. These are the few states of India. Currently, Maharashtra is reporting maximum number of cases, more than 14 lakh cases. Maharashtra has already reported with more than 39,000 deaths, followed by Andhra Pradesh, Karnataka, Tamil Nadu, Uttar Pradesh, Delhi, almost 3 lakh cases. Delhi has already reported, West Bengal, Kerala. But if you see the trajectory in these states, like Maharashtra, now it's in the decline phase. Andhra Pradesh, it's a decline phase. Whereas in Kerala, currently Kerala is one of the fastest growing state in terms of your COVID-19 cases. Why this happened? So if you understand the dynamics of disease transmission of COVID-19, this happened because Kerala initially achieved these low number of cases through very strict implementation of your various non-pharmaceutical intervention. But as I mentioned earlier, you cannot keep all these interventions for an indefinite period. Whenever you will lift all these restrictions, then there will be resurgence. And this is, Kerala is one of the example. So India had an unprecedented lockdown for entire country on 24th March. It's 22nd March, we had one day this your Janta curfew. And then on 24th March, that time we had only around 600 something cases. And India announced this lockdown, pan-India lockdown. That was a very strict strategy, and ideally that should be the last option for controlling any this type of pandemic. If you fail in other non-pharmaceutical intervention measures, then, and if it's required, definitely you have to. But we implemented in very initial stages. If you see the number, but there was a gradual increase in the number of cases. Currently, we are number 1 in the world. So we can't say that lockdown was very successful. We can say we delayed for some period of time overall infection. We all know that the infection depend upon mainly 3 things. One is the period of contagiousness. The second is about the likelihood of getting infection from each contact with a infected person, and if a non-infected person is come in contact with that person. And the third is this contact ratio. Through lockdown and other approach, we can decrease this contact period with decreased mobility, etc. But that should be the last option for any. Everybody was talking about the Kerala model till July, August. Kerala model was the one of the successful model. And initially Delhi reported maximum number of cases. So then they reported that Delhi was a failure model. So there are various school of thoughts about these models. See what happened in Kerala. I have already explained that Kerala during initial phase, they implemented very strict restrictions, and this happened, and this way they control the spread of the infection. When they lift these restrictions, then there was a resurgence, and currently Kerala is the fastest growing state. Delhi, see, since beginning, the number of cases were reported, and then Delhi reached a peak during last week of May and June, and then there was a gradual decline. This happened because of natural infection, not because of and all the sero survey reports are in support of that only, that these declines are because of your natural infection, not because of like a few districts reported more than 25% of the infection rate during June, July. Then somebody said that in month of September, again resurgence of cases, but these are not the resurgence of cases. Actually, these are artificially created resurgence because of the testing. Because of this testing, this time from June to August, overall testing, per day testing was somewhere between 18 to 20,000. So we reported around 2,000 cases per day during that time. So from 4,000 to there was gradual decline up to 2,000 with the same testing number. Then after August, the number of tests gradually increased from 20,000 to 60 up to 60,000. And if you will increase the number of cases, then what will happen? Then you will detect more cases. So this was just added few cases. Why I'm saying so? If you compare the two sero survey reports, that time when Delhi reported 2,000 cases, there was a estimated more than 40,000 cases per day occurred during that time. So we detected only 2,000 cases per, and an average 2,000 cases, because we tested 20,000. If we tested more than 20,000, 40, 60,000 that time, then we could have detected a few more cases from these 40,000 cases. Either they were asymptomatic, so there was no need to detect these cases. Either they were asymptomatic or symptoms were not severe, so they didn't report to the health system. This happened. So you cannot say that Delhi, and they are very unlikely that Delhi will ever face, Delhi or other major cities like your Mumbai, Chennai will ever face a second peak or second wave. It's very unlikely. May happen, but whatever evidence we have, I can say that it's very unlikely, because this is happening because of the natural infection. So a few cities have already, few districts, like in Delhi, few districts have already very close to the herd immunity. So the big question is there end of any? We have sufficient time now. Yeah. Is there end of this pandemic? What is the answer? How long this pandemic will continue? We don't know. We are not astrologer, but we are scientists, so we can say sooner or later this will end. And how this will end? Through the herd immunity only. This is the only way. How can we achieve herd immunity? There are only two ways to achieve herd immunity, either through natural infection and or through vaccine. These are the only two ways. And for all the major this type of communicable diseases, we control through the herd immunity only. We control polio through herd immunity. We eradicated your smallpox from entire globe through herd immunity. The herd immunity is the only way. How will you achieve herd immunity? Currently, we don't know. Just one slide for this concept of how herd immunity play a role in this controlling any infectious disease. Suppose in first box, it's a completely naive population, and one infected individual enters in this population. And if that individual is capable of, suppose, just like COVID-19, infecting 3 to 4 people, then what will happen? This individual will infect 3 to 4 people, and he or she will become immune. It's a self-limiting disease. The majority of people will become immune. Few may die. Then these 3-4 people, they will infect another 3-4 people, and this way almost they will infect the entire population. If in another scenario, if suppose your 70% population is immune population, and if same person enters in that 70% immune population, either they have developed this immunity either through natural infection or through your vaccine. So what will happen? This person is capable of transmitting infection to 4. But because this person is surrounded by many immune person, very few are non-immune person, very few are susceptible person. So like in first box, out of 4, 1 is your susceptible. So he will transmit to this susceptible person. Then that person will become, which is transmitting infection to another person, will become immune, and the another person is now that person is surrounded by only immune person. So then this person can't transmit infection to others. And then after some time, because it's a self-limiting disease, this person will also develop immunity, and there will be a natural death of this virus. This way, these are 4 people in this population. They are, although they are susceptible, but indirectly these immune population, they are protecting to these persons. So this is the indirect way of protection. So herd immunity means indirectly you are protecting susceptible population through, in this case, 70% population, they were immunized. So they are, all these are protecting this. So this is a example of how herd immunity play role in controlling infectious disease. This was the example, like I said that there are 3 serosurveillance. 4th, then Delhi again going to start 4th serosurveillance. So in June, the overall prevalence, seroprevalence was 23%, 22.9%. Then August, 29.1%. But in September, there was decline. This could be due to various reasons, maybe because of some sampling problems. Could be because of your, after 3 to 4 months, IgG level is declined. There are few evidences that IgG level decline. This could be due, but this does not mean that if IgG level is declined, then you are not protected. So we all know that body immune system is a complex system, and both cellular immunity and humoral immunity play an important role. IgG level, we are detecting IgG level. That means we are only detecting your humoral immunity, not on the cellular immunity. There could be a possibility that cellular immunity is also playing an important role. So serosurveillance in COVID-19 in India. Sir, I'm giving a speech on this. So after 10-15 minutes, this India serosurveillance, the first was conducted by Indian Council of Medical Research in 0.7. That time the prevalence was 0.73%. If you convert into the numbers, then for the entire population with 173 population, even after this strict lockdown, if you convert this 0.73% into number, then what is this? That means this is your almost more than 1 crore. So even during May, when this survey was conducted, and May, in middle of May, survey was conducted, and IgG takes some time to develop. So for detectable level, so baseline should be around your 30th of April. So around 30th of April, there were total number of cases in this country were around 35 to 36,000, if I recall correctly. And the serosurveillance estimated that there were more than 1 crore. That means we detected, and that time we had strict lockdown. Even that time, the estimated number of cases was more than 1 crore in this country. Although ICMR has published this data that in above 18-year population, there were an estimated 64 lakhs people had infection that time. 64 lakh was too much even for that time when we had lockdown. So it's a clear-cut indication that we cannot prevent this disease. We cannot prevent. We can only delay progression with some non-pharmaceutical intervention, and even that to minimum. There are other surveys also in various other cities like Mumbai, 57% slums and 16% non-slum area. This survey was conducted during July 2020. Excuse me. Then Chennai, Ahmedabad. And see, all these serosurveillance surveys are also indicative of really they are matching the number of cases and progression made in this area. Like if you recall in June, in Mumbai, that slum, Dharavi, which is one of the largest slum of Asia, reported maximum number of cases. But now it's not reporting. It's not because of some other factor. And although many people are talking about Dharavi model, if you're talking about any Dharavi model, then what is this 57%? That means even with strict restriction because of the population structure and other mixing pattern of population, almost around 60% people got this infection. And this way, this is the natural way of control. We never control this through any magic stick. Although we are talking about that Dharavi model is a successful model, then now we are talking about the Delhi model, also successful model. A model could be a successful model if with this model your infection rate is very low. If suppose if with all these strict measures and if in Dharavi the infection rate is suppose currently if it's only less than 5% or 10%, then you can say definitely it's a successful model and you have control. And Dharavi is not reporting cases. But if we are near herd immunity, this is the natural way of control. There is no big deal in this. So these are the various serosurveillance conducted in India, and that means, and these are the clear-cut indicative that there is a wide community transmission all over country. Now coming to vaccine. Throughout world, around 200 vaccines, there are candidate vaccines. Few are in preclinical stage. Sorry. Few are in the clinical stage. Your almost 42 vaccines are in the different phases of the clinical, and 151 are in the preclinical stage. That means they have not started human trial yet, but 42 vaccines they've already started. Few are in phase 1, few are in phase 2 and phase 3, and few are in the very advanced stage. Although one vaccine, this Russian vaccine, Sputnik, government has already approved, Russian government federation, on 11th August. After this phase 1 and phase 2 trial only, the sample size was also, they have published this, was very less than 50 in phase 1, less than 50 in phase 2. In our country, we have few vaccine, candidate vaccine, and they are in the phase 1, phase 2 clinical trial. Phase 1, this Bharat Biotech vaccine, the sample size was more than 300. Even phase 2, it was more than 400. For this Sputnik, they have, after only with this small sample size, they declared that vaccine is very safe. They declared the vaccine is very effective. And that's why this vaccine created very controversy all over the world, especially amongst the scientific community. So these are the few, there are various type of these vaccines, and the advanced stages. The few are in the phase 3 and few are in the phase 2. Now I was talking about this last one, COVAXIN, which was Bharat Biotech. It's a completely indigenous vaccine. So one is your China, originated from China, CanSino Biologicals vaccine. This is adenovirus vaccine. Another one is from the Oxford vaccine. And in India, Serum Institute of India is collaborating with this Oxford vaccine. This is also in phase 2, phase 3. In other countries, it's in phase 3, but in India, it's in phase 2, phase 3 phase. This is also an adenovirus vaccine. Then again from China, this is inactivated vaccine, Sinovac. From Sinovac, then from Johnson and Johnson. This is also non-replicating viral vector. Then the Moderna from US, messenger RNA-based vaccine. This is in the phase 3. So the last one is also inactivated vaccine. It's a whole virion inactivated vaccine, and in India it's a completely indigenous vaccine. So these are the various vaccine in the different phases of development in the entire world. Vaccine status India, we have 2 indigenous vaccine. One is COVAXIN, developed by Bharat Biotech. Actually, the virus isolation was done by Indian Council of Medical Research during the initial phase of this pandemic in March itself. Then with the help of Bharat Biotech, they developed vaccine. And currently we are doing this vaccine trial. Phase 1 is already over. Phase 1 by phase 2 trial is going on. Phase 1, the first part of phase 1 is over. We can't say that we have completed phase 1. We have to follow all these participants for 6 months. So it's already going on. Phase 2, we have already started for this, and we have recruitment of phase 2 is already over. Even the almost second dose is also, we have already given in this phase 2 trial. Then this Zydus Cadila also, it's an your indigenous vaccine developed by Zydus Cadila as a DNA vaccine. This is also in phase 1 by phase 2 clinical trial phase. And one third one is developed by Oxford. We have already discussed this. So what are the various challenges for vaccine? Developing a safe and effective vaccine is a really big challenge. We don't know what will happen. Whatever evidence we have, we can say that up to this level, 2 to 3 months, this vaccine is safe. But we can't guarantee for a long-term safety. We can't guarantee for a long-term effectiveness of this vaccine. So it's a big challenge. long-term side effect of the vaccine. So again, related with, like this happened with many vaccine in the past when we launched this vaccine, like if you recall, measles vaccine was launched during 60s for the first time, and there are many adverse events, serious adverse event reported with measles vaccine. Then we changed measles vaccine. We stopped giving measles vaccine that time, and then this also again happened with influenza vaccine in 1976 with fear of pandemic. US launched this vaccination program against influenza, and there were large number of cases were reported from US. GB syndrome cases were reported, so they stopped after 2 to 3 months. And overall harm of vaccine was more than the benefit, so they stopped for some time, and then they again changed this vaccine, and a new vaccine was launched. Distribution of vaccine, how will you distribute to them in this country, for this country or for the entire world, especially for the third world population? It's really big challenge. So how will everybody will get vaccine? Then the management of cold chain logistic, uh, especially in the developing country, is also a big challenge. Coverage of adequate population to achieve herd immunity. And we don't know about the answer of few of these challenges, but these are the challenges. How will you distribute to more than 7 billion population of entire world? So it's a definitely a big challenge, and only time will say something, will speak about this. So what is the role of vaccine in controlling ongoing pandemic? Currently, we can say that vaccine has no role in the and current ongoing pandemic control, because we don't have any vaccine. So if today I want to control, then I will not rely on the vaccine, and we don't know vaccine will come or not. What will the fate of this vaccine, effective vaccine, will ever come or not? We don't know. Currently, we are hoping that okay, after some time, 3, 4, 5, 6 months, we will have a good, a very effective vaccine, a very safe vaccine. But currently, we don't have, so we will not rely on it. So all our program for containment of this COVID-19 should not be based on this hope of vaccine. We must prepare ourselves that suppose even if vaccine is not coming, then what will happen? How will you control this? So what is the way forward? So we all know we don't have any very effective treatment. We don't have any effective vaccine. Then how to eliminate or control this disease? And the only way is through the various non-pharmaceutical intervention. Through intervention, we can reduce this. That even the threshold of your this what you call herd immunity. So we can reduce the threshold of this herd immunity also through non-pharmaceutical measures, like wearing every time mask, regular and proper hand washing, avoiding your overcrowded places, maintaining physical distance. So all the social distancing, follow the maintaining the social distancing norm, etc. This way we can definitely reduce the burden, and the whole idea should be to just to play to the curve. And at least, and we can say in this country now it's 8, 9 months, and so now few weeks ago almost, now we are seeing that most probably we are near our peak. Younger person with comorbidities should also exercise appropriate cautions, protecting high risk population, including elderly and those with comorbidities, should restrict their outdoor activities. So these are the few non-pharmaceutical interventions through which we can delay the progression. We can reduce this threshold of the herd immunity, and we can also play to the curve. This one, pragmatic testing as a control strategy. Currently, what is happening? More than 10, what we are doing? We are testing more than 10 lakh per day. If you understand the natural history of this disease, for any this type of pandemic, large number of testing is required during the initial phase. Currently, we know hardly we are detecting less than 5% of the total estimated cases. So our focus should be on mitigation, not to uh, not to detect the cases. If you are only detecting 5% of cases with huge expenditure per day, more than 10 lakh testing means more than 100 crore rupees we are spending on this. Almost, if you estimate the price, then it would be around 100 crore rupees. So do we need this type of testing strategy? Why we need? The current, if you are not able to prevent with this type of testing strategy, then we can use all these resources in some other strategy, and that other strategy should be in controlling this problem in various high risk group, etc., or those who are in the need. So only the testing should be now the testing. We recommended earlier that kindly increase the test to prevent the spread of disease. Now we know that disease has already spread in the community. And with all these measures, hardly we are detecting 5% of the total estimated cases as per our serosurveillance reports. And serosurveillance are the best evidence. Currently, we don't have any better evidence than the serosurvey. These number of testings are not any evidence. Through this, you are detecting few cases only. So there now it's time to change the strategy. Our focus should be to reduce the death. So provide best possible care those who are in the need, not to test everybody. Use all these resources for the best possible care. A few states are really in weekend lockdown or 2 to 3 day lockdown without any stated objective. We don't know what is the objective of this lockdown. Why you are doing? See, for initial stages in this country, when the government of India launched, that could be justified. Like that time we were not prepared for this type of pandemic. We didn't have face mask or PPE kits, etc. Our hospitals were not prepared. So that time we can justify this lockdown up to some extent. Okay. But currently, after 7, 8 months, what is the purpose of? So we don't know the objectives of this lockdown. There is a need to also change this quarantine isolation policy also. Currently, this is creating more your stigma rather than this should be citizen-friendly measures. Opening of school, it's a very sensitive issue. Almost all over world, almost each and every country, they have opened now schools. UK, there are certain resurgence of cases, as I shown earlier in that figure. But UK said that no, there is more harm of closing these institutions. So even suppose if you are going to implement lockdown in near future, we will not close the school. And there are same risks like others. And whatever surveillance we have, that indicate that even children are also infected. 30 to 40% children are already infected. So what is the rationale of closing this school now? And they are causing more harm in children than opening. There are some fear that if you will open these schools and colleges, then there will be a resurgence of cases, or they will bring this infection to the family members. If 30 to 40% of population so are already infected in few cities, then at least we can open there. We know that in this area, 30 to 40% population are already infected. Children and other family members are also infected. and they are at the same rate. So now it's time to move towards normalcy. There are other this your human resource, huge shortage of human resource throughout this country, and there is a need to fill these. Now, this increase healthcare expenditure to 5% to GDP. When Government of India launched this National Rural Health Mission in 2005, that time the overall expenditure was around 9% of the total GDP. Government of India committed that by 2012 they will increase to 3% of the total GDP, but still it's a 1.3%. So if you want to manage this type of pandemic or in future pandemic, then you have to spend on your public health infrastructure. This is the only way for future. So this is the way forward. You must invest. There is a need of a public health cadre. Many committees, national committees, since 1946 board committee, they recommended that creation of this public health cadre throughout the world, throughout India. And after this board committee, many other committee also recommended. But the problem is still we are not having a pan-India public health cadre. Few states have public health cadres like Gujarat and Tamil Nadu, and that's why they are better managing this type of pandemic and other disasters. So you must be aware about the way a very common phrase, unity is strength and division is the weakness. But in this current situation, it's otherwise. If you are united, you will fall. That means in overcrowded situation, if you are together, then definitely you will suffer. If you are divided, that means you are keeping a distance, then you are safe. So keep a safe distance, and thank you very much. Thank you.
Thank you, sir, for your presentation. I think it was very informative for the delegates. And if you'd be kind enough to entertain a few questions, if the delegates.
Sure, why not? I'm always ready.
So someone is asking if there is a probability of any one person getting infected again. Means, is there a chance of reinfection?
See, if you recall, a few cases of reinfection were reported from first from Korea, South Korea, in April, May, right? There were around 90 cases reported from South Korea first time, and few cases during that time, April, from China also. Then finally they found that these are not the reinfection, these are the debris of the virus. See how we are detecting COVID-19, mainly through RT-PCR. Even if presence of dead virus is there, if dead virus is there, the RT-PCR can detect. So in majority of cases, so they finally found that that was not the reinfection. Then again, few cases were reported from, one case was first reported from reinfection, confirmed reinfection case was reported from Hong Kong. So what they found, they investigated this reinfection and they found that this was a completely mutant variety. That person was completely asymptomatic, and that was an incidental finding. That person was returning from some other country, and during routine checkup at airport of Hong Kong, they found that he was infected with again COVID-19, and they maintained digital database. So the computer said that, oh, this person was infected earlier also. Luckily, they had preserved previous sample also, so they matched, and they found that the recent one was completely a new mutant variety. So that was not actually reinfection, that was actually a new virus, so new infection. Then again, next was detected from US, and few cases from India also reported, right? This is really see, whatever global evidence we have, there are more than 3,500 infection has already occurred throughout the world. At least we can say up to 5-6 months, this virus is only 8 to 9 month old virus. So up to this level, we are protected. We don't know tomorrow. Tomorrow we may change our stand, and that protection is only for 6 months, 7 months, 8 months. But based on the global evidence, we can say we are protected for long duration time. Suppose if you are not protected through natural infection, then vaccine is also follow same principle. Then if natural infection is not protecting, then there will be a very doubt about this efficacy of all these vaccines also. Okay.
Yes, sir. Just one more question.
Sure.
Now that various mutant varieties of the viruses are developing, so how will the existing vaccines that are already in development phases, how will they hold up against this mutant strain of viruses?
See, the global evidence suggests that it's not a major mutation, right? In very few cases, major mutations, and that in those cases, it's not very contagious. That's why if, the current, we can say the current vaccine development program is based on this assumption that there is no major mutation. Okay, if major mutation will occur in COVID-19, then same like your influenza, every 6 months we require a vaccine for influenza because of this shift and drift. If suppose same is happening with COVID-19 also, then you will not have the same vaccine every time. And this vaccine will not be effective for a very long period of time. But currently, we don't have this evidence that a major mutation is occurring. Yeah.
Thank you, sir, for your time. And I think everyone is eagerly waiting for the silver bullet, the vaccine that will help protect us against COVID-19 virus and end the pandemic. Thank you, sir.
Thank you very much. Thank you.